the trigon. And of course, then we talk about the control of the urination, the pelvic nerves, the spinal nerves, the brain, of course, is very important. Patients who have some neurological disorder like multiple systemic atrophy, they can present early with frequency. Sleep problems can manifest as nocturia, but actually the underlying problem is they have a sleep disorder. And of course, hormonal production by the body, diabetes, and also antidiuretic hormone from the pituitary gland. So all these are part and parcel of when you treat a patient with urinary symptoms. There must be the absence of pathological disorder. Okay, so when you treat patients in this category of OAB, they should not have a bladder tumor, for example. This patient has got a huge bladder tumor and is treated by the doctor as OAB. Okay, but at the same time, they can have a pre-existing OAB, like some of the urologists in the audience maybe. These patients have been treated for years with OAB, and now recently they have new symptoms. They can also have underlying, for example, a pelvic tumor, cancer cervix, or bladder carcinoma in situ. Or they can have a new pathology like a spinal compression. So OAB can coexist with serious pathology. So do not dismiss it as well. The other important thing that I learned as I grow older after working for so many years is that actually patients who have this OAB, they have a lot of other associated symptoms. In particular, this publication, that many of these patients have irritable bowel syndrome. So they have urinary frequency, they also bowel frequency, they change in bowel habits, they also have change in urinary symptoms. And not only that, they can have other systemic, non-specific complaints like intermittent migraine, headache, asthma, pelvic pain, groin pain, anal pain, scrotal pain. So this often coexist together with OAB. And so, of course, they are the more difficult to treat group of OABs. So it may be possible that there's a systemic cause of OAB, some underlying immunological, or maybe even neurological, or maybe even psychological cause of OAB. When patients come and see a doctor, can come and see you for urinary symptoms, it's important to listen to them carefully to see what they have done to cope with urinary symptoms. Quite often, they have reduced their social interaction. Okay, and quite often they also reduce their traveling. Of course, this is not the only reason of this now, it's because of COVID-19, but some of them, they stop their hobbies like dancing, for example, dancing, or they go for long mahjong sessions. So this is important. And of course, we should not end up in a situation where they actually modify their urinary symptoms so much so that they have modified their lifestyle so much so that to cope with the urinary symptoms. So they can actually get help from medical personnel. So what are the medication that is usually given for patients with urinary symptoms? The commonest medication is to give them a drug to stop the contraction of the bladder, an anticholinergic. Okay, these are the muscarinic receptors. Okay, so this specific medication is called the anti-muscarinic drugs. Anti-muscarinic drugs. And of course, the whole body is full of anticholinergic receptors in the eyes, in the salivary glands, in the heart, in the brain, in the gastrointestinal tract. So giving patients this group of drugs have got a lot of side effects, and that's why there's a strong move to move away from this group of drugs, especially in patients who have any of these underlying conditions, especially in elderly people. So in fact, you may be considered as not giving good medical practice if you persist in giving patients an anti-muscarinic drug if they have any of these conditions. So it's a very important point that I would like to bring across. But these drugs has already been used for many years in the government practice, in pediatric practice. We use a lot of oxybutynin. And in fact, if you go traveling, you can even buy the transdermal oxybutynin. And in many of the practices in Malaysia, Singapore, and Brunei, many of these anti-muscarinic drugs are available. Right now in the Malaysian government service, you can get Vesicare or solifenacin. Okay, but these drugs actually work as an anti-muscarinic. It stops the bladder contraction, so it may not be exactly appropriate for every patient with OAB. This is the over-the-counter medication you can buy in many of the international airports, but they have got external use only and warning. So if you've got urinary problems, you've got diabetes, you've got any other serious conditions, that you cannot use this medication. So these are the serious conditions that is listed here. Okay, so anti-muscarinic drugs are very widely used for a long time But I think nowadays, for many conditions, it's no longer deemed the first-line treatment. So in 2019, I gave a lecture in Kuala Lumpur, and that was the time when this drug called mirabagrone was introduced to the market, and this works by a different mechanism. Okay, it works by the adrenergic beta-3 adrenergic receptor mechanism. Okay, so it's a beta-3 agonist drug. So it's an adrenergic kind of drug. So adrenergic kind of drug, it doesn't work on this pathway. So now we have an alternative medication which we can use for urinary symptoms, in particular urinary frequency and urgency. So I shared my experience at that time, and now it's 2 years down the line. So I review again recently my experience with the use of these drugs. I look at my patient demographics, and most of my patients are male patients. Okay, more male patients. But of course, I'm a urologist, and the female patients will tend to see either the family doctor or gynecologist. So the female patients actually do not see a urologist in Malaysia. And most of the patients are elderly patients, above 65. So that's because of my practice as a urologist. So in your practice, depending on the type of patients you see, you may be seeing more pediatric patients if you're a pediatrician. And of course, so this OAB affects all age groups. Medications to use in pediatrics are usually off-label. Okay, and the types of patients that I see in my practice, when I analyzed it up to 1 year ago, is many of my patients are actually having urinary incontinence. In other words, patients in Malaysia, we usually will not see a doctor unless they are very severe. Okay, they're very severe. They are wet OABs. Okay, and some patients, of course, they have been taking other medications and they are have not improved. Okay, they have failed antimuscarinic drugs. And of course, being a urologist, I have patients who cross over and from other doctors who have already had a TRP done and they're still wet. And of course, many of my patients have underlying BPO, benign prostatic obstruction. So this is a mixed bag of patients. Of course, if you're seeing elderly patients, the patients can also have other conditions in addition to OAB. So I will go into each group later on. The patients which I see, many of them take the medication for more than a year. And the longest the patients are on, they are taking it for a few years. But I practice in a slightly different situation because most of my patients in my particular state private hospital are state sponsored. In other words, many of the patients have a corporate payer. So my patients tend to stay on the medication for quite long. But of course, in Malaysia, many patients actually buy the medication from the pharmacy. Whatever you say or do, the pharmacists in Malaysia will sell medications to the patient. So sometimes it's a bit difficult to keep track of the actual usage of medications by patients in Malaysia. I can say in one word that actually the medication is very safe, very safe. According to information in the product insert, this has got no effect on the central nervous system. And it has got very little effect on cognitive function. So many patients who are previously taking anticholinergic for years, they are elderly patients. They're taking many other drugs, like for example, Parkinsonism drugs. They're taking drugs for their COPD. They're taking drugs for their psychological condition. So they're taking a lot of medication which can affect the cognitive function already. So the daughter, when they come back from Australia, they're stuck in Kuching, they will Google the medication and say, this anticholinergic drug, this oxybutynin, this dysrositol, they cause cognitive dysfunction. That's why my daughter cannot recognize me now. Dr. Lay give this medication and now my daughter cannot recognize me. So be a bit careful because the patients do check the Mr. Google for side effects. And it's well known that anticholinergics can increase the burden of cognitive dysfunction. What about children? Okay, children, when we give anticholinergics to children, some of my patients, they complain that the child become hyperactive. Now my son not doing well in school because of taking your medication. That medication is to reduce the frequency. But most of these patients, somehow they are Caucasians, they're studying international school. And the other big complication from these patients is that they have constipation. So the anticholinergic not only paralyzes the bladder, it also paralyzes the intestinal tract, the constipation. But as I always suspect that these patients have already an underlying psychological or behavioral problem. And once you give them anticholinergic, okay, that can aggravate the situation. Now, the importance of taking a medication is how long do they take the medication? So previously we used the word compliance. Now the pharmacologists say you use the word persistence. comply means the patient have to comply to you, so it's not a good word. So they said, how long do the patient persist in taking the medication? So when we look at anticholinergics used for OAB therapy in the UK, in the National Health Service, when the medications are all given free of charge, only 30% of patients are taking the medication 12 months. And it's the same thing in Canada as well. So imagine you prescribe a medication to the patient for free and he stopped taking it. Most of them stop taking it at 1 year. Whereas if you compare all the drugs, all the antimuscarinics or anticholinergics have an equal dropout rate. The better one is the new medication, mirabegron. Not so new, it's just been around for some time. So it's mirabegron. The earlier studies are on Caucasian population. This is a study done in Asia, in Japan, and it gives the 3 years is a long time, safety, efficacy, and persistent data for the daily use of mirabegron for OAB. And it shows that the persistent rate is 65.8%. Very good persistent rate for medication, including in Asian setting. So my colleague, when I was training in the UK, Dr. Malcolm Lucas, he presented in the European Association of Urology that actually 50% of patients stop taking medications after 3 months if it's taken for OAB. Okay, mostly due to side effects, sometimes due to ineffectiveness. But if you have no choice, because this is a new drug, mirabegron, is a little bit expensive and you may not get it in some government hospitals. So you may have no choice but to use an anticholinergic or antimuscarinic. You can try to titrate it to a lower dose, take a lower dose, or start with a lower dose and slowly bring it up. Or you can take it at night. So if you got dry mouth, you take it in the morning time. If I'm giving a lecture, my mouth becomes very dry, right? I cannot give the lecture. But if you take it at night, most of the time we are sleeping at night. So it doesn't matter if you have dry mouth. And in elderly people, try not to give them antimuscarinic drugs. Try very hard. And maybe you can start on a lower dosage of the new drug, mirabegron, 25 milligrams. Okay. So these are some of the challenges, some of the ways you can cope with the patient. So I'll show you some examples from my own practice. This is a patient whom I've given medication for OAB. And we know that if you give medication for OAB to reduce the bladder contraction or the bladder sensitivity, they may have difficulty passing away. And the patients, I've got a special line, I've got a special phone that I give to my patients for them to WhatsApp to me. This is the way we have to communicate nowadays. So he said, I cannot take your anticholinergic. Basically, it's anticholinergic. Because I'm scared. Sudah makan, saya kencing sangkut. And so he's not taking antimuscarinic. And he's also taking, so I gave him a beta-adrenergic agonist, Pemiga. And he's about 60 now. So I gave him the dual therapy for prostate. But he said, tapi tak ada perubahan. So in one slide, this patient tell me the whole story about treatment of urinary symptoms and the patient's fear of urinary retention. So and of course, patients are very educated nowadays. They say, I take this medication, is my prostate getting smaller? Ada kurangkan bengkak in the prostate. So this is the modern era of medical practice. We have to be able to engage the patient and to be able to answer them. So what about mirabegron? What is the significant side effect? It is an adrenergic drug. Okay, so if you've got a high blood pressure, you should not use the medication. But I look at it this way: if the patient got hypertension, don't you think the hypertension must be treated, all right, before you give them a drug for OAB? So actually, in clinical practice, I don't have much problem with hypertension and mirabegron because the patients with hypertension should have the hypertension treated first in the first place. Of course, we know that in Malaysia, hypertension, for whatever reason, is poorly managed. What about if patients got an underlying prostate concern, like the patient just now who WhatsApp to me? So we have to treat the prostate as well. We have to treat the prostate as well, treat the obstruction or relax the prostate or give them a drug to shrink the prostate gland. So you have to treat the underlying condition. The same thing if the patient got the underlying metabolic problem. If the patient got diabetes which is uncontrolled, blood sugar of 20, of course they have urinary frequency, of course they have nocturia. If the Parkinsonism is not treated or over-treated, of course they also have problems. If the patient got a lot of other conditions of the elderly, insomnia, depression, and poor mobility, constipation. So of course they have all these things to be treated together with treatment of urinary symptoms. And of course, the best person to treat it, of course, is the family doctor. Of course, some patients go and see a geriatrician. Now, I will have to elaborate on a few clinical trials, but just very briefly, on the safety of the use of treatment for OAB and underlying condition. A common one that in my practice, because I'm a urologist, I see patients with prostate concerns, is that of using an alpha blocker. So patients who have got slow urination, we give them an alpha blocker like tamsulosin, and they still have urinary symptoms. We add on with mirabegrone, and we find that from this plus study, I'll show you a few slides on the plus study, that this group of men, almost 1,000 men, treated for 12 weeks, and they find that it's very safe. It reduces the frequency, it increases the volume they pass urine. A lot of patients say that, doctor, I pass urine very often, every hour I pass urine, and the urine volume is very small, so they want to pass bigger volumes. And of course, it reduces the urgency. So if they're driving a car, they don't have to stop the car to go to the nearest toilet or the Shell station, or there's some of them in Kuala Lumpur. I was told that they use a plastic bag in the car as well. So it improves their quality of life on top of treatment for the prostate concern. I'm a urologist, and now there are about 100 other urologists in Malaysia. So we know that if you have a problem passing urine, if you have bladder outlet obstruction, if you go for an operation, for example, a TURP, transurethral resection of the prostate, of course, there are now many other modalities of treatment of prostate obstruction. The result is excellent. See, this is before treatment with surgery. This is already patient already on an alpha blocker, in this case, Zatral, and the flow rate is only 6.7. Normal is 15. After the operation, the flow rate is 22.9. The flow rate is excellent. But do you think the patient is happy with the urologist? He's not happy with the urologist because he said, I'm not concerned about the flow. I drive slowly home. Like me, I drive slowly home. The only concern is my wife thinking I go somewhere else, but actually, I'm not concerned. But my concern is my nocturia and urgency. And after the operation, it became worse. Because the operation is to relieve the obstruction so that it passes urine better. And because you've got OAB, it worsened the frequency and nocturia. So of course, these patients actually require treatment with treatment for OAB. So OAB treatment is important. Many doctors actually try to fit their treatment into their own scheme of affairs. They do not listen to the patient. Actually, what is the patient's concern? We must treat the patient's concern rather than what we think is good for the patient. So if the patient has already taken another drug, they have already taken an anticholinergic drug, anti-mercenary drug, and it doesn't seem to work, should we give them this new drug? Okay, the study says that it does work. You can give them either separately or add on off-label another medication for the urinary frequency. So this is called the BELIEF study. The BELIEF study, patients who are elderly patients in the European countries who take mirabegrone in clinical practice shows that they, over a period of 2 to 12 months, yes, and patients who are above 65 and under 65. So this big study shows that mirabegrone is extremely effective to treat OAB symptoms in all age groups, in particular patients above 65. This is the group that have got cognitive problems. Okay, so this is the summary slide from this study. As I said, I'm not going to spend too much time on clinical studies. And then finally, about sex. Is sex important in life? Of course, sex is very important, and we often forget that female sexual function is also very important. So this is one such study which is published in BMC Urology, that actually patients who are treated for their OAB have an improved function. Usually we don't have such studies, very few such studies, but obviously it's obviously intuitive that treatment for urinary symptoms or any symptoms at all will improve the sexual function. Now, of course, sexual function is a very important cause of underlying, often undiagnosed depression or anxiety. One common question that patients ask is, how long would people like to take OAB medications in Malaysia? So if you tell the patient that you take the medication for a long time, they will not be so keen. But actually, the medication can work on the same day. After all, the Tmax is 3 hours. In fact, it can work within days, and some patients actually keep the medication to take as required basis. In other words, they take the medication when they go traveling. So the patient countered me with another question. He said, "Doctor, in that case, can I just buy 1 week supply of medication? Or maybe I just buy 1 day, or you give me some samples." But the problem is that urinary symptoms, urgency, frequency, doesn't just depend on one factor. It depends on how much water you drink. It depends on your psychology. It depends on your exercise. So usually I tell them that if you want to see whether medication works for your urinary symptoms in the long term, it's better to use it for a month or 3 weeks. And anyway, most pharmacies will sell you 1 month supply. So the patient should start on the medication for 1 month. Then the next question the patient like to ask me is that, not the third question. Now, do I have to take the medication forever? Now, I can tell you that if you tell the patient that you have to take this medication for your urinary symptoms forever, they are not going to start, because nobody wants to take medications. Well, most people don't want to take medications forever. So I will tell them that this is actually meant for long-term use, but there are many other ways that you can modify your lifestyle or your bladder care that you may be able to take off the medication. Right now, the published studies, I think now it's up to 5 years already, that this medication is safe in the long term. Okay, another situation that I often face is that patients say, "I want to stop taking the medication. My sister is good now. Thank you very much. You are a wonderful doctor. You give this medication to my sister. He took it for 1 month. Now she is cured." But in actual fact, if you study the natural history, in fact, you must know the natural history of every disease or every condition that we treat. Many conditions actually improve on their own. 1/3 of conditions will improve on their own. 1/3 will get better. 1/3 will get worse. Most conditions follow this 1/3 principle. And of course, if they change their lifestyle, they can improve. And of course, the condition can recur and they can restart the medication. So that is how of course, in the meantime, I take the glory like that. No, I've cured her for this OAB, but actually probably she's not cured. Now, male patients who take medications for OAB, mirror background in this case, that there's always a fear, so a fear that they have a problem, they will go into retention. They have a fear they go into retention. And this particular study, which is published in 2017, shows that if you take mirror background, it does not increase their post-void residual volume or the acute urinary retention. Okay, that it does not. The scientific studies say it does not. But I have patients who call me, "Oh, doctor, you give me this medication, now my father cannot pass away." Okay, we must always think of confounding factors. It may be that the father has finally taken a flight from Kuching to Kuala Lumpur and he drank a lot of the coffee and things, and then he overdistended his bladder. So it may not be due to the medication, but the studies say that it usually do not cause problems with retention. But if the patient is already predisposed, already have a distended bladder, of course they'll go into retention. So make sure the patient do not already have a high residual volume before you give them the medication. So this is a miracle study, okay? Miracle study. Of course, it gives you miracle results. To summarize this slide, basically, in this particular study, the safety profile between mirror background and placebo is the same. In other words, it is a very, very safe drug for you to use. Okay, of course, this is a study, so all the patients are selected patients. Okay, make sure the patients do not have all the other conditions like untreated hypertension, untreated diabetes, constipation, insomnia, Parkinsonism. So if you put this all together, it is a very safe drug. But in real clinical life, of course, you make sure that all these things are not there. This is a beta-adrenergic drug. Okay, beta-adrenergic drug. So your colleague or the cardiologist or the patient's family will check the medication. Oh, this drug may have an effect on the heart. So some of the cardiologists actually stop the medication when the patient is admitted or seen them for some other condition, tachycardia or whatever. But actually, the studies actually show that there is not significant cardiovascular related events. And what is the thing that they are worried about? Many drugs nowadays have an effect on the QT interval. Okay, QT interval, and they use a very high dose of 100 milligrams. The usual dosage that we use is 25 to 50. Elderly patient 25, other patients 50 milligrams. it actually does not have an effect. Okay, but of course, when the patient is admitted under the cardiologist or physician, I can't stop them. I can't stop them. Of course, after 1 week, the patient will tell the cardiologist, now I've got severe frequency, urgency. Now can I take back the medication which Dr. Lay prescribed to me? Now, I need to spend some time on non-pharmacological treatment because I sincerely think it's important. At the same time, patients will ask you. Patients will always ask you, what medication, what food can I take? What can I do so that I don't have to take medication or I don't have to depend so much on the medication? And bear in mind, medications cannot reverse the condition. In other words, if your frequency of 8 times per day, taking the medication will reduce it to maybe 4 times. Okay, look at the studies I showed just now. But it does not abolish it. So the patient still have to do bladder care. So if you take a lot of caffeine, take alcohol, of course you pass a lot of urine. And you're traveling, always take an aisle seat. And you have to time boarding. Say you're going up for a flight from Kuching to KL, then you empty the bladder first. And of course, medications like diuretics. Some patients take diuretics for some reason in the evening, 6 o'clock, So they've got a lot of nocturia. And lifestyle. Lifestyle have a definite effect on your health. So exercises. So you go for a swim for 1 hour, you have less nocturia at night. Pelvic floor exercises is important. So if somebody stays at home, eats a lot, sit on the couch, become a potato couch, of course, they will have a lot of urinary symptoms. And of course, in children, biofeedback is important. Children who go to school with a lot of urinary frequency, some urgency, and electrical stimulation, either the nerve stimulation or to have implant, this can have effect on urinary frequency. But this is very low down in patients who have very severe OAB, especially the wet OAB in young individuals. So lifestyle have an effect on urinary symptoms. Okay, I got this actually from the internet, so that I know what the patients are thinking about. So the patients and the internet says cranberry juice, okay, in addition to other things like bananas are good for the bladder, okay, especially cranberry juice. There are a lot of studies on cranberry juice. I think it's equivocal. And of course, things like soda, alcohol, spicy food, patients and the internet thinks that it's not so good for the bladder. My answer is actually the patient can try out. The patient can try out from trial and error. They will tell you, oh, okay, my wife said, oh, I don't take coffee. I take coffee, I got a lot of frequency. So of course I take a lot of coffee. So of course it does give you frequency, but it's manageable. What about bladder training? Children who go to school, they keep on going to the toilet. Okay, so how to do bladder training? If you train your bladder, it can behave better. Okay, so you try to increase the interval between each toilet visit, and try to stick to the timing, whether you feel the urge or not. So if you feel a sudden urge, you can try to control the urge. Of course, some people they cross their legs or they massage their finger. Okay, so bladder training has an effect to augment the effect of the medication. So bladder training is an important aspect of treatment of urinary symptoms. Okay, so I show you some personal pictures. These personal pictures. So 1/3 of bladder OAB can get better. 1/3 can get worse. So if you're taking, if you're like me, you're lucky, the patient get better. Oh, Dr. Lay is very good. Or you're taking a herbal, the doctor sent from Australia, after taking the herbal, they feel much better or say the herbal is good. Okay, so this is a natural history of OAB. And bladder care is important. If you have frequency, you empty the bladder before and after the event. Okay, before you go into the cinema, empty the bladder. Otherwise, halfway through the James Bond movie, you have to go and pass urine. And exercise. And if you're traveling, of course, you have to bring the medication. So some patients take the medication PRN as required. So like me, I'm going for holiday with my daughter to New Zealand and it's raining, I bring my umbrella. In addition to bringing my umbrella, I must bring all my medications, especially my Bimiga. Okay, exercises is important. There's me exercising in my backyard. And of course, food is important. Okay, kiwi fruit, bananas, vegetables, plain water, don't take alcohol. So all these have an effect on your urinary symptoms. Of course, it has an effect on all the other medical conditions as well. Now, what do you think is the general practitioner's idea about OAB? So this doctor referred me this patient, 32 years old, mother of 2 daughters, spontaneous vaginal delivery, another delivered by lower segment cesarean section, frequency, passing urine, many months, no dysuria, nocturia, it must be more than 10 times. Diagnosis, query OAB, refer Dr. Clarence Lay. This is the guarantee letter number. Okay, so this is very, very important as well. And if you check the urine normal. So actually, I think that over the last 2-3 years, there's a lot of community doctor awareness, but the doctors are still reluctant to treat OAB. And only a handful of doctors actually use medications, especially newer drug background. I think probably because maybe there's concern about the cost, maybe concern about side effects, maybe concern about referring patients. So there's still a lot of concern in the community to treat OAB effectively. I don't know why. This is another patient. This is in Sarawak. In Sarawak, so all the patients in Sarawak, when they go and see a government doctor, clinic kesihatan, they will have this. This is a patient-based medical record. Okay, every patient will have the vital signs taken. Nowadays, of course, they have their pulse oximeter and the temperature taken. And this patient, this doctor is extremely good doctor. He took the IPPSS score, the International Prostate Symptom Score, and you look at it. The patient can pass urine very well, no weak stream. But the patient's complaint is frequency, some urgency, no diabetes. Okay, not only do the fasting blood sugar, they even do a on-site HbA1c, and they also do a rectal examination, prostate is enlarged. But unfortunately, instead of giving the patient a medication for OAB, overactive bladder, he was given an alpha blocker because the senior discussed with the senior FMS. I think you all know what is FMS. I think it's family physician, family medical specialist. They decided over the phone that this patient requires an alpha blocker. So of course, it was given the wrong medication. Now, when do you actually have to refer a patient? I had a meeting with a panel of non-neurologists in 2019. Non-neurologists means gynecologists and GPs and physicians, cardiologists. So if you have any of these conditions, we agree that you have to refer. If the patient got pain, patient got blood, patient got any neurology, numbness of the leg, weakness of leg, not walking, poor memory, or the patient has frank incontinence, wearing pampers or putting a condom or wearing a plastic bag, and the patient's already taken the medications for a couple of months, or if the patient is elderly, because elderly patients, generally speaking, they are taking too many medications. They have polypharmacy, and also we worry about pelvic tumors. And of course, the patient himself also doesn't know how many medications he's taking, and the carer also want to reduce the number of medications. So I think these are the 5 cases where you have to need to refer to a urologist. And of course, most urologists, in fact, all urologists I can say will practice collaboration. They will have a joint management. They give you a medical report and manage the patient jointly with the family doctor. So in my personal practice nowadays, for patients with OAB, I'll give them mirabegron, especially in older people. Okay, younger people, because of the availability of the medication, especially in the public sector now. Public sector, I think it's available in public sector, but there's a bit of you have to arrange for it. There's some budget concerns, and especially if the patient has got side effects already, constipation. Some patients already have constipation. You give them anticholinergic, it will be worse. But in younger people, we can give them anticholinergics. And in children, because I think most of not safe. Most of the drugs are not tested in children. So they are not. If you use them, it's off-label use. And in Europe, we have got syrup mirabegron. Syrup oxybutynin has been available for at least 30 years. So in children, sometimes we fall back on anticholinergics, but they are used off-label, and the parents must understand that. So I'm going to give you some guidelines. I'll give you some guidelines. Malaysian Urology Association, we do not publish guidelines anymore because we signed an MOU with the European Association. So I give you the summary guidelines of the use of anticholinergics, use of beta-3 agonists, in other words, mirabegron, in the use in various conditions. The first condition is patients who are already using antimuscarinics. Okay, you can use it. You can use mirabegron for patients who are already on muscarinics. It's just as efficient. The adverse events are minimal, similar to placebo. And according to EAU, not according to the practice in Malaysia. In Malaysia, if you use it, it's off-label. You can use it together. You can combine it with anticholinergic if the effect is not sufficient. You can dose escalate it. That is European Association. What about cognitive function? Many elderly patients have urinary symptoms. Okay, so if you use antimuscarinics, it is effective. If you use a beta-3 agonist like mirabragan, is also effective, but the problem is of cognitive function. And it's well established. There are many studies to show that the earliest anticholinergic oxybutynin have worsened cognitive function in elderly patients. Okay, so there are some others which have got less effect on cognitive function, but they are short-term studies only. So generally speaking, we try to avoid long-term use of anti-muscarinic drugs, anticholinergics in elderly patients for the treatment of OAB. Okay, this is another guideline to emphasize on the importance of antimuscarinics. Now, antimuscarinics, if you find in the market, there are many generics, but generally speaking, the extended release have got less side effects. The extended release instead of the fast release have less side effects. And if you're not effective, you can add on beta-3 agonists, and you have to review them to look at the side effects, and especially for patients with urinary incontinence. You can also combine it with pelvic floor muscle training. Usually we try to send them to the physiotherapist, but the physiotherapists in the government hospital are always very busy. They are thinking of training the muscle, moving the joints, so they are not so good. But in the YouTube nowadays, there are plenty of good videos on pelvic floor training. Now, many patients who see us with urinary symptoms also have underlying prosthetic concerns. So it is proven to be safe that you can combine an alpha blocker. There's so many alpha blockers: tamsulosin, alfujosin, tarajosin. Okay, some doctors even use the older prajosin. So you can combine it together for the relief of symptoms. But be careful with the post-void residue. So always examine the patient. Always do abdominal examination. If possible, do an ultrasound and do a rectal examination. Because if you give them patients who already have 300 cc's, you may tip them over into urinary irritation, and they'll not be so happy with you. Okay, so what about the Americans? The American Urology Association, their guidelines also says that you can use a beta-3 agonist for symptom control if the symptom control with antimuscarinic is insufficient. You can do a combination therapy. Again, this is guideline. If you use it, you will be off-label. So my last slide now, almost last slide, second last slide. The take-home message is that mirabragan is a beta-3 adrenergic agonist. It can be used in the treatment of OAB. It's very effective for patients for using as a first line, or you can use it in combination with other medications. And it's also safe in patients for whom you cannot use antimuscarinic. Example, patients with glaucoma or patients with impaired cognitive function, and it has a much lower incidence of side effects, especially dry mouth. And I think this drug actually gives you a very good balance for efficacy, tolerance, and adherence. So this hopefully will convince you that this drug is a safe drug. You can use it for patients with urinary frequency, urgency, incontinence, even if they have underlying conditions of prostate obstruction, with cognitive dysfunction, with glaucoma, and very minimal or almost no side effects. So thank you. Make it a great day. And I'm talking to you from Kuching. I'll be happy to take questions and answers. Try to discuss your cases with you if you like. Thank you so much. Hello, good evening. That was actually my pre-recorded lecture. Thank you for joining me today. I suppose we have to pre-record it because the situation in Malaysia is not exactly, we got flooding, we got thunder, we got new political parties. So I hope you enjoy the lecture. And what I'll do now for the next 10 minutes, I will address some of the Q&As. So in every lecture, there must be good Q&A, right? Okay. So let me just see the first Q&A.
I have is about diabetes. And of course, there's a very appropriate question because diabetes probably is the national disease in Malaysia. So diabetes, the question regarding diabetes, what about hyperglycemia and urinary frequency? Of course, that is the case, but often the patients in my practice will come and say, doctor, my blood sugar is 5, 6, very good. So I ask them, when do you take your blood sugar? Oh, I take the blood sugar last Monday. And he, of course, he has been fasting for the last 2 days before the blood sugar. So they must check the blood sugar regularly throughout the day. So if they have a lot of nocturia, they must check the blood sugar at night because sometimes they have a nighttime glycemia. So the blood sugar, of course, must be controlled. No point taking medication if the blood sugar is not controlled. The other problem about diabetes is caused diabetic neuropathy. So they cannot empty the bladder well. So they have an underactive bladder rather than overactive bladder. So how do you manage an underactive bladder? Get them to pass urine regularly, maybe even double voiding, and also reduce the fluid intake before they go out. So this kind of time voiding, time fluid intake is important to control the frequency and symptoms from diabetes. Now, in the end, many of them will actually have retention of urine. So you bring to see a surgeon, the surgeon might do an operation for the prostate, but after the operation, the patient still cannot empty the bladder well because the bladder is underactive. So in that kind of cases, then the bladder should be emptied with a catheter intermittently, either by the patient himself or by the carer. And if they're in a nursing home, maybe sometimes they can use a overnight catheter. So giving drugs for frequency, doing operation for retention of urine in diabetes is quite often the wrong treatment. So that's the first question. The second question is regarding patients who have got prostate problems and frequency, whether they should take Hanal. The question asked by the person is Hanal and Biofeedback, whether they should take both the medication together. I would usually not do that straight away because first of all, it's very expensive. Okay, maybe about $15. It's a lot of money for Malaysians. Secondly, if you give them the alpha blocker first, if they empty the bladder well, quite often the frequency and nocturia will be decreased. So you have to give them an adequate trial of alpha blocker before you give them medication for the OAB. The third question I have on the chat here is regarding what does FUNI mean? F-U-N-I. I think somebody answered it in the chat as well. It means frequency, urgency, nocturia, incontinence. And strange enough, I actually learned that from my daughter. My daughter, when she was doing her urology posting in London, and now she's actually in the intensive care unit. And I can tell you, she said half the ward is COVID-19 patients. COVID-19 patients. So actually, COVID is still quite bad now in many countries. So we're quite lucky in Malaysia. So that's funny. What's your advice for diabetic, hyperglycemia, Biofeedback? Okay, what about using of Biofeedback in females? As I said, in my practice, I don't have that many female patients because I send them all to the gynecologist if they come and see me to do a proper gynae checkup. Look for things like cancer cervix, atrophic vagina. Sometimes you can give them, the gynecologist can give them some local estrogen cream, which can help them. And if that fails, then I suppose we can also move on to elderly female. The question is on elderly female with mixed incontinence. I suppose you can try by Biofeedback, but don't forget the lifestyle measures that I mentioned. Okay. Any concerns for the anesthetist regarding the drug you're going to give the patient for surgery? Yeah, very good. This is a very good anesthetist, very good anesthetist. So of course, because in private practice, we often get the anesthetist just about taking any patient at all. Okay, so urological drugs on perioperative care. The alpha blockers, they can cause problems with the eye muscles. In particular, the iris muscles. So they can have a thing called a floppy iris syndrome. So the ophthalmologist must know about it before they go for surgery. Preferably, we stop the medication for a week before the surgery. And then the other thing is that of course the beta adrenergic have an effect on the hypertension. So sometimes if the patient is going for surgery, maybe they should stop some of the medications for a few days before they go for surgery. And okay, finally, I think my time is up now. I will give some concluding remarks. And one of the things that, as a urologist and a senior doctor, we're also interested in health, health in general. And my message to the doctors who log in today is that you must take care of your own health, especially in this COVID-19 pandemic. And how do you take care of your own health? I think very important, you must have exercise. Make sure you exercise every day. 2, exercise comes with dietary intake. Dietary intake, I mean, eat less, okay? Eat less carbohydrate, sugar, take more fruits, vegetable, vitamin C, vitamin D, and of course, you must have adequate relaxation. Don't spend too much time on the internet, and control your body weight and have a healthy lifestyle, and spend more time with your colleagues and listen to more webinars. Hopefully, I will have another webinar coming up soon on men's health. Thank you for your attention.